The House Appropriations Subcommittee on Medicaid and Behavioral Health will come to order. Clerk, will you please take the roll call?
Chair Van Workum?
Here.
Vice Chair Green?
Present.
Representative Roth?
Here.
Representative Kuhn?
Here.
Representative Robinson?
Here.
Vice Chair Rogers?
Here.
Representative Glanville?
Present.
Mr. Chair, you have a quorum.
Thank you. Representative Green moves to approve the minutes of the March 11th meeting. Being there no objection, the minutes are approved. Today, we're going to do a little deeper dive on the psychiatric hospitals in the state of Michigan. We have Amy Epke, the Senior Deputy Director, Financial Operations Administration, Department of Health and Human Services, and Dr. George Mellows, Deputy Director, State Hospitals Administration, Department of Health and Human Services. Welcome to the committee. We look forward to your testimony, and we'll have the members ask questions after your presentation. So thank you for being here.
Good morning, and thank you for the opportunity to be here today. As mentioned, I'm Amy Epke, Senior Deputy Director of Financial Operations, and I'm joined by Dr. Mellows. Today, we are going to talk about the state psychiatric hospitals, provide an overview of the 4 facilities. We're also going to provide an update on the renovations and construction that's occurring in Southeast Michigan at the new facility. And then I'll briefly touch on a budget investment that is included in fiscal year 2026 associated with the new build that's occurring as well. We're just going to briefly provide an overview today, and we look forward to any questions you have. I also know, talking to Sade, that we are willing to do a tour for for anyone on the committee as well to get a better understanding of the facilities as well. So with that, I'm going to go ahead and turn it over to Dr. Mellows.
Thank you, Amy, and thank you for having me here today. I know they refer to me as the senior deputy, but around the country, I'm just the superintendent of state hospitals. That's what they call our position. And I want you to focus on our mission, and that last word, community, is very important. That we provide evidence-supported and person-centered inpatient care to people who need help through probate process and forensic process with reintegration into the community. Our tightest connections are with community mental health. People come to our facilities through CMH and they leave into CMH in the probate process system. Of course, it's different with forensic process, which we'll get into in a little bit. So we have, at this time, 4 state hospitals. The Caro Psychiatric Hospital, a new facility, built around the year 2020 and occupied 2 years ago now, with 100 patients, and it serves the blue area on the map. That's its catchment. Kalamazoo Psychiatric Hospital, with about 115 patients at this time on average, serves the orange section in the southwest part of the state, west-southwest. Walter Reuther is a combo facility, serves southeastern Michigan for adults, and then for kids, the entire state. So it's a combination facility at this time, children and adults. The Center for Forensic Psychiatry in Saline focuses on forensic process for the entire state of Michigan. Our throughput last year, we had 669 admissions and 678 discharges. So that's approximately 1,400 patients came and went. We like to see a throughput number of about 1, and certainly the numerator and denominator, as they bump up, decreases wait lists. We currently have 23 individuals on the probate process wait list. That's non-forensic, 5 adults and 18 kids. The 18 kids is the hard number. There's a soft number that's about twice that high. There are 252 people on the forensic process wait list, and that is 180 individuals in jail and 73 individuals on bond. We have worked diligently at reducing the probate wait list, adults from about 60 to where it's at today, as you can see on the graph. And we have slowly whittled away at the children's wait list also over the past year by increasing throughput. Our forensic process wait list, the competency evaluation wait list in particular, is what this graph shows. We started out around 500 behind at the end of the pandemic, and we've gotten that down to 276 through extracting efficiencies in evaluation process at the Forensic Center. In terms of the facilities and our update on the new Southeast Michigan Psychiatric Hospital, the facility, if you're familiar with Northville, is where the old Hawthorne Center was and across the street from Schoolcraft College on Haggerty Road. We got a $325 million allocation fiscal year 2022 for design and construction, and an additional $51 million was appropriated by the legislature fiscal year 2024 through DTMB. Demolition of the old Hawthorne Center was completed December 2023, and construction began at about the same time with the new facility. The building will be turned over to MDHHS from DTMB in June of 2026, so it's just about a year from now. Hospital staff will, of course, be trained extensively from June until when we move in October 31st, hopefully right around that time, 2026. The site plan for the new facility, as I said, it's on Haggerty Road, across the street from Schoolcraft College, between 6 and 7 Mile, just to the east of Legacy Park in Northville Township on about 40 acres. You can see with this image that there are 4 adult units and 3 kid units divided by a central administrative and recreation complex. And that is a drone image of the facility looking at it from the east to the west. You get a sense of scale. And again, drone image from over. And a depiction of what the front of the facility will look like. It fits in very well with Northville Township construction, if you're familiar with that area. The new psychiatric hospital building specs, about 206, well, there will be 264 beds, 24 beds per patient care unit, 192 adult beds in 8 adult units, and 72 pediatric beds in 3 pediatric units. There is a lot of space dedicated to education for both adults and kids. Of course, the adult and pediatric spaces are highly walled from each other. Amenities will include a gymnasium, exercise rooms, art rooms. There will be horticulture space, some great courtyards, and 4 quiet sensory rooms per unit. And in addition, per unit, we will have a couple of rooms for patients who need specific programming. The other psychiatric hospital infrastructure enhancements, the Center for Forensic Psychiatry, CFP in Saline, was built in around 2005. That's when they moved in there 20 years ago. The facility had analog phones and no kitchen, and furthermore, the parking lot and the entry area had some updates that needed to be done. So we're working on the kitchen project now. And you might wonder, how does a facility run without a kitchen? It's tough. The food is prepared at Walter Reuther, and then it's trucked over every day. We're transitioning to digital phone service, and it should be done over the next couple of weeks. The entrance, like I said, needed substantial updates, as did the parking area. And then the facility built in 2005 was not built with current ligature specifications, so we've had to have a unit closed at the facility over the last year, bringing up each unit to date in regard to ligature. And that includes upgrading door access locks and intercom systems. As you know, it's a forensic facility with very dangerous patients, and so it has to be highly secure. Kalamazoo Psychiatric Hospital, a fascinating place built primarily between, believe it or not, 1858, before the Civil War, to about 1940. It's a structure that we're highly dedicated to keeping up to date, which has meant over the past 5 years completely having to do fire suppression systems with significant upgrades necessary on each unit to bring it up to date in regard to asbestos, ligature resistance, and fixture replacements. And we basically rotate a unit or two. There are 2 currently offline where we're making these repairs. And now I turn it over to Amy Epke, budget update.
All right, good morning again. I'm just going to briefly talk about the budget that is supporting the psychiatric hospitals. So you can see on this slide, the total state hospitals budget is $396.5 million as proposed in 2026, with the largest amount of funding going directly to the state psychiatric hospitals, a small portion going to administration and other areas. One thing I will note that in addition to what we're showing on this slide, we also work very closely with DTMB on special maintenance needs, as does other departments as well. So you may see some special maintenance funding in the DTMB budget as well, as we partner closely with them to identify what infrastructure needs there are and work to prioritize those needs and funds. The next slide just shows the funding sources supporting the state psychiatric hospitals. You can see the largest source of funding is general fund at 77%. And then finally, I just want to wrap up with the investment that is included in the fiscal year 2026 budget. This is a $15.2 million investment. This is to support the staff necessary to support the 264 beds that will be available at the new facility. That is an increase in number of beds from 54 beds, and there is also an increase in staffing to make sure that we can support those individuals as well. So you'll see that recommendation in the fiscal year 2026 budget, and we look forward to working with you on that proposal. So with that, that concludes our presentation, and we're happy to take any questions at this time.
Thank you. Thank you for your presentation and taking the time to be here and answering our questions. Representative Green has a question.
Thank you, Mr. Chair, and thank you. Long time no see, Amy and Dr. Mellows. Looking at just the totality of the mental health system in the state, we consistently hear from locals about struggles trying to get people out of an emergency room into a psych bed, or in the CMH world into a psych facility. So how is that process? And then from your perspective, is it efficient to get individuals into the hospitals? And I guess sort of follow up with that would be, how many of your beds are NGRI versus a normal treatment so that we can prevent them from becoming NGRI?
Most people in emergency rooms who need behavioral health care will be hospitalized in the private sector at facilities like Cedar Creek, for example. I'm thinking of something local here. A very, very low number, usually people with high and severe behaviors that can't be managed in the private sector safely, would be petitioned into state hospital with CMH approval. And anyone who comes into state hospital in the state of Michigan has to be approved for a state hospital bed. And then furthermore, if Medicaid drawdown is needed, that also has to be approved. So there are 2 levels of approval for people who, depending on insurance. So getting into state hospitals it can be difficult. We have a wait list right now of 18. We brought it down from 60 approximately a year ago. So there is an improvement in throughput there. We work closely with community mental health if it appears that a person is more of a placement issue, and that is often the case with people stuck at ERs, meaning that They have complex histories that might include serious self-abuse behavior and substance use, and people with those issues and developmental disabilities should be, and typically can be placed in other places if our teams get together and think about where they can go. So we're often meeting with CMH and people from central office to get people out of ERs. I know some people are stuck for a very long time, and that's disturbing to me, and I wish we could take them in. We triage carefully our probate process patients to make sure that we can take in people who we know we can treat, and that would be people with serious mental illness. As you know, people's histories are very complicated, often brain injuries, serious substance use, intellectual disabilities, very complicated histories that don't fit a psychiatric model well, and are better housed and treated in the community. NGRI, probate process, I should say, versus forensic process. In Michigan, we have typically about a 60-40% split, meaning 60% are forensic process patients and 40% are probate process. Other Midwestern states have gone pretty much to a forensic, like Ohio, for example. It's their state hospitals, 90% forensic process, 10% probate. So they have flipped primarily into forensic process, as many state hospitals across the country have. And interestingly, Ohio does have I think they have close to 1,200 psychiatric beds too, state hospital beds, about twice as many as we have. I don't believe we need more. I think we just need to improve our throughput.
With a follow-up, you had mentioned that on the financial side, on the probate side, you're looking at funding from the CMHs as well as insurance. If a person is found on the forensic side that they have committed a crime, but they're not guilty by reason of insanity, the payment for them comes out of the general fund rather than a court system or something along that line. Am I correct with that?
That is correct. And really the bottom line with the NGRI people is that they are probate patients. They're at the facilities through Chapter 4 probate process. Their designation is NGRI, so there's quite a bit of oversight by the NGRI committee in regard to their treatment care and services, both in the facilities and when they get de-escalated to the community, if we can get them into the community.
Representative Rogers.
Thank you, Chair. Thank you for your presentation. Of course, I'm very interested in this since I represent Kalamazoo, and Kalamazoo Psychiatric Hospital is in my district. So can you talk a little bit about, Rep. Green, my colleague, touched on this a little bit, but in an earlier presentation, it was brought to our attention that it is more costly to treat people in private hospitals. I think the number is around $850 for a private versus a state-run psychiatric hospital of $300. So can you talk a little bit about how the state came to this shift in prioritization and how that is impacting the cost to care for people in private facilities versus a state-run facility?
I'm going to have to check on that $300 figure because I think it's quite a bit higher than that. The per diem, I believe, is what you're talking
Yes.
about. It's probably closer to 1,000. And we'll get you more information on that.
Okay, thank you. And then following up, can you talk a little bit about the number of beds overall and the need out there? So I did ask House Fiscal the numbers, and they provided from 2004, it was around 1,200 beds, and now we're down to a little bit less than 600, which you outlined kind of on the slide. So can you talk about that overall number of beds going down, particularly how that's affecting wait times? Because I still get calls from my hospital CEOs around people, as you referenced, getting kind of stuck in emergency rooms.
Yeah, a big facility closed in 2003, 2004, the Northville Psychiatric Hospital, not to be confused with the new one, but So that was a big loss of beds, huge loss of beds. And the primary loss of beds came from that. Currently, we have about 700 physical spots that we can hospitalize people in. Our census is at about 560 right now on average, and the reason for that is that we have two units closed at KPH and one closed at CFP. And we have also had to reduce the adult census at Walter Reuther in order to accommodate youth. We're hopeful that, well, indeed, the unit at CFP will open at the end of this month in a couple of weeks, and we'll gain 34 beds from there. And then at KPH, I'm hopeful that the construction will be, cross my fingers, that's all I can say about that place. But the construction will be done at the end of this calendar year, and we'll be able to open up two more units there and get our census closer to 150. So that'll get us into well into the 600s at that point, above 650, I'm hopeful. And we have had an incremental increase in the number of direct care staff we've been able to hire. People are starting to come back to work. And furthermore, I think that the bump in wages, the 5% bump for all state employees, has helped retain staff. Our retention is pretty significantly increased. So we're facing improvement instead of deep concerns about direct care staff numbers. Over time, we're trying to hone to the Department of Labor standard of about, in a hospital, of about 1 shift per pay period. And you have to very tightly control that, otherwise you get into trouble with injuries and other accidents in the facility.
Thank you. I appreciate you highlighting that the trend is coming down in terms of the time and the backlog of cases. But I will say I still have, significant concerns as judges and hospital CEOs continue to reach out to me with people that have difficulty getting placed. Thank you.
You had mentioned direct care workers and people coming kind of back to work and the retention. When I look at the budget and House fiscal analysis, I see you're down about 600 FTEs. And as we look at it, having state employees cost less than having contracted employees. Maybe you've got a different perspective of that, but that's what we've been told. Can you give us a little insight there of why so low on the FTEs and how much of the budget is being used then for contracted employees?
The contracted employees are primarily professional employees, just to be clear to everyone here. They are not direct care staff. They're not bargaining unit staff. So the contractual employees are primarily physicians, some psychologists, and at Walter Reuther at the dietary department. And it does cost more to pay contractual physicians to work at the facilities. In terms of the dietary department, it breaks even. But psychology and psychiatry is more costly. And our biggest chunk of FTE deficit comes from the direct care staff.
Is that an issue of being able to recruit?
It is recruitment, certainly, although that's bumped up just a little bit in the last year or so, and that's been reported across the country. Retention has improved with increased wages. Actually getting people to come into facilities, and again, this is talking to colleagues across the country, has more to do with a restructuring of wages, salaries, and benefits.
So the ratio that you had just mentioned prior to this, what is the true then FTE count that you need?
I'd have to get you that information specifically for each facility. It's different for each facility out of the 600 that you mentioned.
Representative Roth?
Light came on now, finally. Sorry. Thank you, Mr. Chair. Thank you guys for being here. In the special maintenance fund in the budget, maybe tell me what all that's in that, or generally. What I am concerned about is having a fund that replaces windows or broken whatevers that are ripped off walls or that kind of thing. Does it come out of that special budget, or if somebody knocks out 50 windows because they go on a rage, do you have to come back to the legislature for that, or can you use that special budget to do so? Or is it calculated in the budget?
Yeah, so that's a great question. So the answer is it depends. If it's small enough, it can come out of the internal special maintenance fund. In some cases, if it is a significant structural issue, we will have to take it kind of out of other savings, potentially from vacancy savings in other areas as well. And then again, we also do work with DTMB on special maintenance projects as well, if you're involved in their capital outlay project as well. So it's a combination at times, but certainly I think, there's continually more we could do in that area to make sure that we are addressing the significant special maintenance needs at the hospitals.
And if you don't mind, Chair, has there been any instances like that over the last 2 or 3 years?
I can let Dr. Mellos speak specifically to that in terms of the damage to the facility and what's happened internally.
Yep. So there is damage in the facilities, particularly KPH and Walter Reuther, which will be no longer occupied a year and a half from now, at the older facilities. Quite a bit of damage, quite a bit of annual need for repairs and updates, like I said before, in regard to water management, asbestos management, et cetera. At a properly constructed behavioral health facility like Caro, it's close to zero.
All right, thank you.
Yep.
Representative Glanville.
Thank you, Chair, and thank you both for being here today. I think I missed this, but statewide we have 650 beds total. Is that what I heard?
It's closer to 700 beds,
Okay.
physical beds, but
Okay.
like I said before, it's
Sure.
tough to occupy them all because of updates that need to be done.
Right. And what is the actual need? I might have missed this. I think it was asked, but I didn't catch the number exactly.
Yeah, the actual need is probably closer to 750 to 800 in that range, and that will be covered with the new facility opening. Like I said before, other states similar to Michigan, like Ohio, have twice the number of beds. We're in the lowest 10% across the country in terms of numbers of beds. Being able to work closely with the community in order to increase that throughput and decrease time in a facility is really what we want.
Sure.
As opposed to having people in state hospital beds. Once you're in a state hospital bed for about 3 months, you start to lose touch with the community. You lose that language, and it's tougher and tougher to reintegrate.
I appreciate that because my next kind of leading into it was really looking at the children's hospital in particular and our juveniles and where they're housed in the psychiatric hospitals. There's only one facility that handles juvenile patients.
There are several private sector facilities, again, like Cedar Creek, just thinking locally, and there is one state hospital. Probably about half the states, I guess the last NASHPED inquiry we put in, have pediatric state-level psychiatric beds. So it's not every state that does.
Okay.
And again, we want kids in the community
Sure.
as much as possible because they're particularly vulnerable to institutionalization. And we have stood up in behavioral health a PRTF, Psychiatric Residential Treatment Program, with about 40 active beds right now, and we're going to be gaining quite a few in the next 6 months, where we can hopefully be able to have a number of youth be placed as opposed to need to be in a longer-term facility like ours.
Okay. Thank you.
Thank you, Representative. I got, I guess, a few questions related to the consolidation that we've seen or reshifting we've seen over the past couple of years here. I guess you've been very careful to say the closure of Walter Reuther. Is there any plans for what that facility will be used for in the future?
There are no plans that I'm aware of. Amy, are you aware of any?
Not at this time.
No.
Okay. Do we have a cost estimate of how much it's going to cost the state to just maintain or have that property on the books?
We could get that to you. I mean, it is MDHH's property, about 10 acres in the River Rouge floodplain, in a building that is really very difficult to maintain.
So, I guess for committee's sake and maybe all the folks in the audience today, and maybe for my own sake, so Caro just went through a big renovation, shut down Hawthorne. Those beds moved to Walter Reuther. Walter Reuther is now being shut down and moved to this new place that is on the former Hawthorne site. So within that process, there's been some consolidation. And from my understanding, when we closed the Hawthorne facility, the budget moved over to Walter Reuther, and then those dollars were also work projected. So what wasn't consumed could also be used yet for ongoing costs, and I think maybe some of it was for the capital as well. And when I look at this budget, including the administrative line and things like that, doing all this, reducing the amount of beds, consolidating, where is the state seeing cost savings in this? Normally when you do a consolidation or a merger or things like that, the state will see, or the entity doing that would see cost savings. Can you point to some cost savings or some numbers that we have seen through this process?
The cost savings are on a couple of different levels and will become more clear when we move into the, or more manifest, I should say, when we move into the new facility. For one thing, there will only be one administrative structure. There is only one administrative structure. So there are administrative costs that have been recouped. And, for instance, we'll only have one director, only one chief of clinical affairs, only one director of nursing, so that, and that just, flows down the line in terms of administration. And again, will become more manifest upon moving into the new facility. And then also not having to spend millions and millions of dollars every year to keep up Walter Reuther, the flooded basements, the elevators that don't work, the, management of water and making sure that it's safe for people to drink in the facility, replacement of coolers, of chillers, et cetera. It's just endless. A very concerning facility. And we saw that certainly at Caro too. Spent millions of dollars trying to keep that place going for decades until we had the new structure, and the cost savings in regard to that are manifest at this time.
So again, kind of going deeper line item in the budget, would that administrative and the consolidation of that administrative, would that be on the administrative line, or would that be on each individual hospital line? And on top of that, I saw through the governor's recommendation that you are trying to roll up all the psychiatric hospitals into one line, so we wouldn't be able to see between the 4 or 5 different hospitals. Can you explain that recommendation?
Yeah, great question. So as far as the roll-up, certainly we will report out all information on the separate hospitals. That is not intended to withhold information or anything like that. That is instead right now what's happening. In some cases, we'll have one hospital that might have some savings and one that might have some type of special maintenance issue that comes up. And right now, it's very difficult to shift between those lines. We do have to go through a legislative transfer or supplemental process, which sometimes can take months when the need's a little more urgent than that. And so that is really intended to be able to hit on some of the questions that we heard from earlier. How do we get to those special maintenance projects and things like that as well, too? And then I think, in terms of the financials, as Dr. Mellows mentioned, there definitely are some savings. We also have to take into account, though, that we're increasing the beds. So it's not like when you look at the lines, you're going to see, a big reduction in the cost, because at the same time, we're increasing the beds as well, too. So all of that is factored into the numbers. But we are very happy to provide whatever reporting information would be helpful to this subcommittee and still report at the hospital level.
When you are referencing increasing the beds, you're referring specifically from the transition from Walter Reuther to the Northville site, but
Correct.
overall, the beds have gone down over the years.
Correct.
Representative Rogers. That's Ken's fault. Representative Lambo.
Thank you. And my apologies. I'm just having a hard time kind of wrapping my head around this. So where are the patients who aren't at the state hospitals who need to be at the state hospitals? Are they all just in emergency rooms? You've mentioned Cross Creek a couple of times. I'm sorry, I'm more familiar with Pine Rest. Are they housed in those facilities? Like, where are they?
Yeah, they are in those facilities. Most patients who have behavioral health needs that require a hospital level of care are in private sector psychiatric facilities, like those managed through UHS, Acadia, and Pine Rest, et cetera. That's where most of them are.
So is that funding accounted for in this? How are we paying for that, or who's paying for that?
Private insurance and Medicaid, and it's not part of this budget at all.
Okay, but are they counted in your numbers of who needs a bed?
No.
So if those facilities weren't taking in these patients, we would have a much higher need.
That's correct.
Okay, all right, that's helpful. Thank you.
Thank you. Going back to the line items and the funding of the difference, I see here in your presentation that you're only requesting 15.2 million is that for the Southeast facility for this fiscal year? Is that correct?
Yeah, that would be a fiscal year 2026 increase above the existing ongoing budget. So 15.2 million is what's proposed as the increase in 2026.
Okay. 15.2 increase, I guess, then from the Walter Reuther facility? Is that what we're saying? Okay. All right, thank you. Well, I want to thank you guys for coming. I thank you for being a resource as we go through this budget process. I'm sure we will continue to be in touch as we unwrap this budget and understand the needs and the continued shifting that we're seeing with the state hospitals. So thank you very much for being here. Seeing no absent members, there's no further business. The meeting is adjourned.